Hello, coders. Today we're going to start to talk about evaluation and management services. This is the PowerPoint that goes with the step-by-step textbook. And so what we'll be doing first is we'll be going through all the key concepts of evaluation and management in this lecture. And then in the next lecture, we'll start breaking down the book itself with our notations. So first thing, let's talk a little bit about what evaluation and management services are. In your code book, in the first section on the 2018 CPT book, it is a red section for evaluation management. Now, you'll notice that all of these codes start with 99, which in general, when we think of 99, we would think it should go at the end of the book. And these originally started at the end of the CPT code book when they became codes. However, because they are the most common CPT codes used in the outpatient setting, the American Medical Association has moved them into the front of the book for the ease of coding. So you will see other 99 codes when we get into medicine. However, evaluation management is always at the beginning. So evaluation and management are a combination of our outpatient services, such as office visits and consultations, but it's also going to include emergency room visits, nursing home care, hospital daily visits, newborn care, critical care for neonates, pediatrics, and adults. And we have other services that we're going to see, such as some of the newer services that deal with the physician working with multiple specialties to get the patient the type of care that they need. So the first thing we have to remember is when we're coding for services, your job is always to code what is documented in the medical record. If it's not documented, it didn't happen. And so if you're looking through a medical record and there's information missing, that's when we go back and query the provider. Ask the provider for clarification to make sure we understand. It's not questioning them in that they did something wrong. What we need to make them understand is we want to make sure we code the exact right code for the service they provided to the patient. And in doing that, we want to make sure that everybody gets paid. And so when we need clarity, we always go back and query the provider. Okay, so again, we optimize, we never maximize. So optimize means that we get the most out of it. So we use the documentation that the provider gives us to be able to code for these services, but we don't maximize them. We don't try to increase services just because we feel like it. However, again, this is all based on documentation. There will be cases that will be very high-level office visits. Think about someone who just had a myocardial infarction, a massive heart attack. They're going to take a lot longer and it's going to be a lot more complex than someone that's coming in for a follow-up on their asthma. So as we go through, we're going to be talking about making sure, again, we code for exactly what we do. Okay, now we have to remember, going back to insurance and billing, coding for services not provided is a crime, okay? It is fraud, meaning that if the services were never rendered, if they were never given to the patient and we bill for them, that is fraud. Fraud can mean that coders and billers get stripped of any certifications or credentials that they get, and it usually leads to that person not being able to get a job in the medical field after that happens. So again, evaluation management services report physician services. So this is the provider. So let's just remind ourselves about who providers are. In general, providers are medical doctors of any type. So that includes all the specialties and subspecialties. Any doctor of osteopathy, which is like an MD, like a medical doctor, but does a slightly different path in their schooling, and all of the DO specialties. Any nurse practitioner in all the nurse practitioner specialties, all the physician assistants in the physician assistant specialties. We are also from time to time going to deal with other types of evaluation and management providers such as psychologists, psychiatrists, and other types of integrated, what we call integrated management, where, again, it's multiple specialties working for the same patient. Now, again, the subsections are by the type of service. Okay, so the types of services that we have are things like the office, the hospital, the consultation. So again, what type of service is the patient having? They're having an office visit, they're having a hospital visit, they're having an emergency room visit, they're having a consultation. That's the type of service that the patient is having. When we talk about how do we code for evaluation management, there's a lot of different words and phrases we need to become familiar with. But keep in mind that most of the information we are covering in this PowerPoint are in your guidelines, and we will go over notations in the next recorded lecture. However, you can write whatever notes you would like in your CPT book. So if you need reminders for any of this information, you can write it wherever you like. In fact, just looking at page 1 and page 3, there's a lot of empty space that you could write notes to help you out. So there are 3 main factors that we use to identify what's going on with the patient. Which E&M code should we use? We need to know the place of service. Physically, where is the patient? Are they physically at the office? Are they at the hospital? Are they in the nursing home? Are they in the emergency room? Where are they? Then the type of service. So here's what we have to keep in mind. The patient might be at the hospital. Okay, but are they having an emergency department visit? Are they having an observation visit? Are they an inpatient of the hospital? Those are the types of services. Now, sometimes the place of service and the type of service are the same. For instance, office and other outpatient services. The place is the office, the type of service is an office visit. But also in offices, we can do consultations. So again, we're going to talk about the different places a patient can be, as well as the different types of services for each one of the subsections. And then the patient's status. The patient's status, we're talking about new versus established patients, patients that have not been seen there ever or have not been seen in 3 years, and patients who have been seen within 3 years. And then what we call initial and subsequent, the first visit and all of the other visits. So again, the place of service is where the patient physically is. So if you start looking on page 1 in your code book, a lot of the places are in the bolded green. The office, hospital observation, hospital inpatient. When you flip the page, okay, we have consultations, emergency department services, nursing facilities, home services. Okay, those are all places where the patient could physically be. Again, the types of services, again, after we know where the patient is, what type of service are they having there? So again, if they're at the office, are they having an office visit or are they having a consultation? If they're at the hospital, are they having an emergency department visit, an observation visit, or an admission to the hospital? And again, we also have discharge as well, because people can be discharged from the hospital and from the nursing home, as well as observation care. Okay, we have, again, 4 main patient statuses. We have new, established, outpatient, inpatient, okay? So the new and established are talking about how long has it been since the patient's been seen. Now, what's nice is if you flip to page 5 in your code book, you'll see the decision tree for new versus established patients. And the key thing is 3 years, okay? 3 years, or again, if the patient's never been seen there. You know, that's another thing to keep in mind. If they've never been seen, they're automatically new. Established patients have been seen within the last 3 years. Okay, so then we have outpatient. Again, so outpatient is anything that's happening in an office, in an outpatient site, outpatient hospital. The difference between outpatient and inpatient, there is a formal admission to the hospital and it is in writing. Okay, most of the time it's an electronic writing now where the patient electronically signs like a tablet, or if the patient's not available to do that for whatever reason, a family member can admit them to the hospital. Okay, that's inpatient. They're formally admitted through paperwork into the hospital or the nursing home. Okay, emergency department and observation, office visits that are at the hospital, those are all considered outpatient. So again, for new patients, they have not been seen in the last 3 years. So here's where we have to be careful. They can't be seen by the same physician, or this is where it gets a little confusing, or another physician of the exact same specialty and subspecialty in the same group. So that is the key, same group. There are a lot of multi-specialty groups out there now that also have integrated evaluation and management with their primary care. One of the reasons why we see so many of these larger doctor groups is because it allows for more stabilization, meaning the doctors know that they could have a certain patient base in that area. There are multiple sites for their patients to go to, multiple specialties, and it can all be in the same network, which is great. So what we need to be looking for is if the patient has been seen by someone in the exact same specialty or subspecialty in our same group. So, okay, this is where what we have to think about here. So if Bob sees Dr. Jones, the cardiologist, and Bob decides he doesn't like Dr. Jones and he wants to start seeing Dr. Smith, but Dr. Jones and Dr. Smith both work in the same group, he is not a new patient to Dr. Smith. Okay, according to the group itself. He is a new patient to Dr. Smith in that Dr. Smith has never seen Bob before. But again, that's different. That's a difference from the billing side. Now, if let's say Dr. Smith works at Cardiology PC, and Mary goes to see Dr. Smith there, and she decides she doesn't want to go see Dr. Smith anymore. And she goes to see Dr. Jones, and he works for internal cardiac medicine. Then we don't need to worry about it. They're not in the same group. So again, when it comes to the coding, we also have to keep in mind the billing side of it. What's nice about it is, since most of our medical facilities have been using electronic medical records for a minimum of 3 years at this point, this is a lot easier to look into in the computer system than having to search through old records. The reason why we have a difference between new and established patients is new patients are more labor intensive because, again, we have to get their whole history. We have to go over all their medication. We need to know about all their surgeries. We need all this information versus an established patient. We already have this information. And so we're doing a follow-up with the patient instead of basically building the patient's chart because they are new. Again, established patients have been seen within the last 3 years, and again, by the same physician or the same or another physician of the same specialty or subspecialty. Now, again, we have to be careful because we have subspecialties. So, for instance, we have cardiology, and then we have electrophysiology. Electrophysiology is a subspecialty of cardiology. And what happens is someone becomes a cardiologist, and then they go back to school and they learn electrophysiology. Electrophysiology, so again, logi, study of electricity. In this case, physio is function. Electrophysiology is the electricity of the heart. So this is the conduction systems of the heart. So again, we have to be careful because a cardiologist could send a patient to an electrophysiologist. They are different specialties, okay? And one is a subspecialty of the other. And so this is why you always ask questions out in the field just to confirm There's also other subspecialties. We don't hear about that often. When we think of OBGYN, we think of just the general OBGYN doctor. But there's also people who specialize in vitro fertilization and people that have had poor reproductive history or people that have had multiples in their births, twins, triplets, things like that. And those are their specialties. So it's okay to ask questions when you get out there to double check what is and what is not a subspecialty of another group. The other difference between new and established patients is established patients have a medical record available. And again, that's the other big part. Their medical record is available. For most states, their record retention is a minimum of 6 or 7 years. So again, we would have to keep these records regardless, because 3 years is not enough time to start shredding records, and that is a federal guideline. State guidelines can be different. State guidelines can give you more time. In Connecticut, we have to keep our records for a minimum of 7 years. And so again, we're going to have the current record, and it's a lot easier for the doctor to be able to quickly look through, refresh themselves about the patient, and then meet with them. Again, outpatient is someone who has not been formally admitted to a healthcare facility. Again, formal admission is paperwork. There has to be a signature, both from the provider and from the patient. The provider has to state the reason why they are admitting the patient to the hospital or nursing home, and the patient, or again, could be a surrogate of the patient or a guarantor depending on the situation, also sign saying, yes, I allow this person or I allow myself to be admitted to this facility. Outpatient facilities are hospitals, clinics, same-day surgery centers, sometimes known as ambulatory surgical centers. Again, same-day surgery can be attached to the hospital, or it can be an ASC, which is not attached to a hospital, but usually they're both same-day surgery centers. Anyone admitted to observation or anyone that is in the emergency department is still considered an outpatient. If someone goes, again, to have a visit with a specialist in an office, it's outpatient. Again, inpatient is someone who has been formally admitted to the health care facility. And again, the attending physician, the person who decides that this patient needs to be made an inpatient in that facility, has to sign admission orders. Again, why are they admitting the person? The H&P, the history and physical. So the history of why the patient's there, the physical status of the patient and what's going on with them. And then any consultation requests. What else does the patient need? Again, this might be an emergency department doctor, but feels the patient needs to see a pulmonologist and a cardiologist. This is all part of what the emergency department physician must do to formally admit a patient to the hospital. We'll also see the same thing on the opposite end. A lot of times, especially those on Medicare, go from the hospital to the nursing home, and the hospitalist in the hospital gives the orders to admit the patient to the nursing home. Now, there are 6 different levels of portions of the services that these are based on. So all of these have their own definitions in your green guidelines, as we will go through. So the basic thing that we need to know after we know the place of service, the type of service, and the patient status, we need to know the nature of the presenting problem. Why are they here? Okay, are they having pain? Are they having a cough? Are they feeling tired? Are they running a fever? What's the nature of it? What's the reason that brought them there? Okay. Then the skill that's required to provide the service. Sometimes it's simple. Someone has a sore throat, they do a throat culture, and the patient has strep throat. However, when it comes to things like pain, pain is very subjective by the patient. It's not easy to pinpoint. So again, it can take more skill. We're also going to be talking about time. Now, when it comes to time, time is not a factor for the majority of our E&M codes unless 50% or more of the total time is counseling and coordination of care. And these are going to be more for patients that have very specific medical needs. Someone who just had a stroke and is following up with their physician. Their physician might need to spend time, describing to them, okay, you're going to want to do this for physical therapy, this for occupational therapy. We're going to set you up for this service and that service. That's all part of this time. However, a lot of office visits, we don't need counseling time because it only takes a few minutes for the doctor to describe what they need to do for us. Again, this time of year, lots of people are going to the doctor, and the doctor is going to decide whether or not they think that the patient's illness requires antibiotics or not. And then they're going to explain why they feel that way and how the treatment should go after that point. That takes about 2 to 3 minutes. But again, there are other more complex conditions that will require more time. Think about someone who's a newly diagnosed diabetic who needs a lot of explanations of what's going to happen next with testing their blood sugar, or someone whose doctor is to sit down with them and tell them they have cancer. That's going to take a lot more time, a lot more counseling. We also have a level of knowledge necessary to treat the patient. So this is one thing that a lot of people forget about. This is the reason we have specialists. Our primary care physicians, our emergency department physicians, they have a very solid foundation in the entire body. Most of them end up doing internal medicine as their kind of specialty when they're in their residency. However, the level of knowledge is very important, that they understand what's going on in the patient's body, but it's even more important when they know when they have to send a patient to a specialist or get a test done to see if they need to see a specialist. This is part of the knowledge of these providers. They need to know when it's out of their scope and when they need to bring someone else in to help treat the patient. There's also the effort required and the effort assumed that we need to keep in mind. So again, we have something that we're going to be talking about called medical decision making. The decisions that the provider is doing to decide what the patient should do. Should it be a medication or a treatment or a diet? Or do they need to go to the hospital? Do they need surgery? So again, there's a lot of effort, and most of it's mental effort, that they're going through to properly make sure that patients have what they need. And again, the responsibility required, because they are responsible for any treatments or non-treatments for the patient. Now, evaluation management codes came well after the other code set. We have to remember that the CPT code book started in 1966, got 3 major overhauls, and now we are in the 4th revision. But the evaluation of management codes did not come until the 1990s. And so they are set up different. They do not look like the surgical codes or the anesthesia codes. So what we're going to see here is, because they're different, because these codes are based upon circumstance and not based on exactly what we're doing. For instance, if we're removing the appendix of an 18-year-old, we're going to end up looking up appendectomy in the index. Then we're going to find the code, look at the code, and I'm just going to tell you now, the separations between the codes are whether or not they are 12 or under or older than 12. So if this patient's 18, we're going to grab the appendectomy. Older than 12, boom, we have our code. It's not as simple in evaluation and management because, again, every patient coming in is going to be different. So when it comes to how we deal with the levels, okay? So when we think about evaluation and management coding, patients can be coming in for something quite simple, a medication refill, an injection, a quick follow-up on their blood pressure or their asthma, or again, they could be coming back from having a massive hospital visit or after major surgery. So what we do is we have different levels. Usually there's 3 to 5 levels in each subsection of evaluation and management that are based off key components and contributory factors. And so let's look at what those are. Now, this is kind of hard to see. I'm going to see if I can blow it up a little bit. I cannot at the moment. This is also in your textbook, and this is part of one of your forums. This is the E&M audit sheet. This is one version of it, so we'll come back to this picture, as we go through. So basically, when it comes to key components and it comes to contributory factors, okay, so we need to know the key components are made up of history, examination, and medical decision making. Okay, the contributory factors are counseling and coordination of care, as well as the nature of the presenting problem. So the more we have of each component or factor, the higher the level of service, the less of each component or factor, the lower level of service. And that's why the E&M audit form can be very, very helpful, because it can show you how to start matching up pieces of information that we find. So again, key components are made up of history, examination, and medical decision making. So we're going to go through each one of these and talk about why each of them is important and how do we pull out this information. Again, contributory factors are counseling, coordination of care, nature of the presenting problem. Now, when it comes to a history, and again, all of this information is also in your green guidelines. We have 4 main elements. We have the chief complaint. The chief complaint is why the patient is there. What was the reason that brought them there? What are they complaining of? They're complaining of a cough. They're complaining of pain. They're complaining of tiredness, whatever it might be. Then the history of the present illness. How long has it been going on? What specifically has been going on? Okay, so if someone's been having a cough, how long has the cough been going on? Are they coughing up anything when they cough? If they are coughing up anything, what color is it? Is it thick? Is it thin? And again, going through the history of the illness. Then a review of systems. So these are our body systems. So the provider is going to review the systems that are directly connected to the chief complaint and the history of the present illness. So if someone's complaining of a cough, they're probably going to check ear, nose, and throat. They're probably going to listen to the lungs. They're probably going to listen to the heart. They might also double check the kidneys and the digestive system, just to make sure that the patient's not having any other distress. But again, are they going to look at the feet? No. Are they going to look at musculoskeletal in general? No. Because again, the issue is someone is coughing up something from their lungs. We're also going to look into the past family and social history. And again, they're pretty much what they sound like. The past history is the patient's past. So we're talking about things like the patient being able to, they have a history of this disease, they have a history of this surgery, what's been going on in their personal history. Again, family history, which is also very important, and social history, which we'll talk a little bit more about, that really more involves what the patient does in their daily life. So let's start going through each and every portion. So again, the chief complaint is the reason for the encounter, and this is usually in the patient's own words. So when you get taken into the actual room by the medical assistant, they do your vitals, they do your blood pressure, sometimes your temperature, your height, your weight, whatever your physician's office does. And then they usually ask you, why are you there? And the medical assistant is supposed to write down what you say in your own words. In that way, when they give your information to the physician, and the physician, or provider I should say, comes in, they have it in your own words, and that's where they start their questions from. So some computer systems and some forms that doctors use will use the phrase chief complaint, excuse me, but even if it's not used, it could say reason for visit, or it could just be at the top of each and every service, again, typed in from the medical assistant. Patient states that they have had a cough for the last 3 days. It's been, very hurtful. They're coughing up yellow, mucus. And again, it's going to be in the patient's own words. Again, the history of the present illness. So again, we're describing the development of the current illness. So when did it start? Or if the patient doesn't know exactly when did it start, when did they start feeling off? One of the things we have to keep in mind is when it comes to our microbes, our nasty bits, our viruses, our fungi, our bacteria, and our parasites, there are the incubation time, and then you start feeling sick. So sometimes people don't know exactly when something started, but they know when they started not feeling well. Usually when you get a cold, about a day or two before the cold symptoms actually hit you, you start to kind of feel a little bit run down. And so that's what they're kind of looking for. Like, when did you start feeling this? When did it start? And what have you been feeling since then? The patient is going to describe the history of the present illness. And then, the provider is going to start, kind of poking and prodding what they're being told to see if they can get more information. Okay, now again, the big thing is if the patient can't answer, you can have a parent or a guardian or somebody else. So for instance, if this is a small child, it's probably going to be a parent or guardian, but this could also be someone elderly. This could be their child or their grandchild. So we also must keep that in mind. And the other thing is that, again, sometimes people just haven't noticed something, but someone else has. For instance, it's not that the patient can't answer for themselves, but they haven't noticed. Maybe you have a 6-year-old that's had a growing spot on their back. Well, if they're not looking at their back in a mirror, they're not going to notice it. So mom or dad or guardian might have noticed it and then gives the different portions. Now, we're going to go a little more thoroughly in the next lecture into the 8 elements of the history of the present illness. And again, anytime the patient is giving this information or the provider is asking them questions, the answers must end up in the documentation. So again, chief complaint of abdominal pain, okay? So it started Thursday night. It was mild. During the night, it got worse. Friday morning, I went to work but had to leave because the pain got so bad. So that's from the patient, okay? That is their history, okay? Now, when we start talking about those components, so the doctor is going to start asking them all about where, how, severity. So the first thing they usually ask is location. Where specifically is the location, okay? In this case, the pain is in the lower left-hand side towards the back. The physician goes on. They're not going to ask about the quality of it. So again, is it sharp? Is it dull? Is there pressure? Is it burning? So again, what's the sensation? So the patient says it's really sharp and it's constant. So the quality of it is sharp. Okay, then we start asking about the severity. And this is on a pain scale. This is where the 1 to 10 comes out. So again, in this case, the patient says the pain is terrible, worst pain I've ever had. So it's probably at a 10 for the patient. That is the severity of the pain that they are feeling. Okay, now the duration, how long has it been going on? In this case, the pain has been going on for 3 days. Okay, so again, we're poking and prodding to get more information out of the patient about exactly what's been going on with this pain. Okay, now the timing, again, is the pain present all the time, or does it come and go? Okay, and the patient says pain just continues, it doesn't just go away. Now again, timing in this case, so if someone's saying I'm sneezing every morning for the first 10 minutes I get up, and then the physician says, well, do you have any other times of the day where you get those sneezing fits? And the patient's like, no, it just tends to be in the morning. That could be timing just as much as this is timing. So again, they want to know, is it something constant? Does it come and go? Or again, is it situational? Again, maybe the person is sneezing because they haven't dusted their bedroom in years and there's dust flying around everywhere. But as soon as they get up and start their day, they move on and there's not enough dust to make them sneeze. Now the context. Okay, so when does it hurt most? So again, is there a correlation like climbing stairs? In this case, they say the pain is just there. It doesn't matter what I'm doing. But again, some pain gets better when you sit down, when you lie down, when you bend over a little bit. So again, the context, when does it happen? For instance, someone's knee might not hurt them until they start walking upstairs. When they're walking around normally, everything's fine. The second they start climbing stairs, it's a problem. So that's the context. When does this happen? And then any modifying factors. Does anything make it better or worse? So again, nothing I do makes it any better or worse, so that the patient tried aspirin and they got no relief. So again, the doctor could possibly go on and ask, well, have you tried hot showers? Have you tried laying on a heating pad? Have you tried putting ice on your back? They might go into other modifying factors to see if the patient's tried any of those. And then again, we have associated signs and symptoms. So again, what else is happening when the problem is present? So when this pain is present. And then we said, yes, I have nausea when the pain is worse. Because again, pain usually indicates inflammation somewhere. Inflammation can put pressure on different parts of the body. And yes, that can make you definitely nauseous if you have back pain. So again, all of these factors are going in to try to understand the chief complaint, okay? So we're trying to understand what's been going on with the patient, and more specifically, how has everything been going? So that's the big thing that we want to keep in mind. Now, when it comes to the review of systems, okay, there are organ systems. We have 14 elements in the review of systems. So our organ systems are actually listed, again, if you look in your green guidelines, so your organ systems are listed on the top of page 10. So it starts with eyes, ear, nose, mouth, throat, cardiovascular, respiratory, gastrointestinal, etc. Those are our organ systems. How do we break down the body? Now, the extent of the review of systems depends on the chief complaint. So again, like I was saying earlier, we wouldn't review the musculoskeletal system for a chief complaint of chest pain, because again, chest pain does not usually come from the musculoskeletal system. Same thing, okay? If we have a patient who has had trauma from an auto accident, then we might not be able to know the difference between whether it is cardiovascular or musculoskeletal. So again, that's why we have testing. So otherwise, in all these visits we're looking at, remember, we have all the testing to try to figure out what has happened if we can't diagnose. The other thing is, again, the organ systems that are going to be covered are going to be directly related to the questions that the physician has already asked and what they find out during the actual physical exam. If they start poking and prodding the body and the patient's saying, ow, in different places where they didn't expect to have pain or things like that, then that might lead them to more organ systems. But again, it has to be documented. Now, one of the things that is always going to be included is what we call the constitutional. Every medical facility has a different constitutional. My primary care's office, their constitutional involves a medical assistant doing your weight, doing your blood pressure, and taking your temperature. Then the doctor is going to come in and they're going to do what we call the general appearance. And the general appearance is, what does the patient look like? Does the patient look healthy? Okay, or do they look pale? Do they look red in the face? Do they look like they've been sweating? Do they look like they have a fever? So the constitutional is just kind of getting the patient ready for the actual visit, getting those basic pieces of information. Okay, so that is automatically included in all of our review of systems, is the constitutional. Okay, so then we're going to have our eyes separate from our ears, nose, mouth, and throat. I will tell you guys right now, when it comes to the eyes, unless it's something very, very simple, the providers are going to send the patient to an ophthalmologist or to the emergency department to meet with an ophthalmologist. Because unless it's like a simple infection, like a pink eye conjunctivitis thing, or maybe a little ingrown hair, an ingrown eyelash hair, primary care doctors don't deal with the eyes because, again, it's really out of their scope of practice. They don't want to ruin anyone's vision. So if you're ever helping scheduling and someone calls in and says, yeah, I think I got a shard of wood in my eye, you want to send that to the nurse, because the nurse is probably going to send that patient to the emergency department or an ophthalmologist. Again, cardiovascular is our heart and our vessels. Again, the respiratory system, starting at the nose, going to the lungs. Remember, gastrointestinal starts at the lips and ends at the anus. Genitourinary. Remember, genitourinary is a combination of the genitals and the urinary system. So again, this is going to be a little bit different if we're checking out one or both of these systems, dependent on whether they're male or female. Musculoskeletal, of course, are bones and muscles. The integumentary system, our skin. Again, we're also going to have the neurological. This is looking at our brain. This is looking at our nervous system. And again, the ability to use the nervous system. Psychiatric, so we're looking specifically at the mind and the way the mind functions. Endocrine, so these are all of our secretions from our endocrine glands. Pituitary, pineal, thyroid, pancreas, adrenals, testes, ovaries, all the endocrine gland secretions. Hematologic and lymphatic. So again, this is a combination of what is inside of our blood and how much. Again, we can have issues with the amounts of different types of blood cells, and the lymphatic system, which, remember, runs parallel to the blood system and has those connections where the two of them meet up in places like the liver and the lymph nodes. We also have the allergic and immunologic. So again, this is our immune response to different, allergies and allergens. So again, we have different ways that we can look at the different systems. And again, depending on how the patient answers those questions is going to be dependent on how we actually complete the actual review of systems, what's going on specifically with the patient, what does the doctor find out in their questioning, and then when they actually start the review of systems, are there any findings that lead them to something else? Now, again, the past, family, and social history. So the past history is going to, again, major illnesses and injuries, operations, hospitalizations. And again, you can look at a full list of this in your green guidelines on page 7, okay? Current medications, allergies, age-appropriate immunization status, dietary status. So again, we need to know about all of these. The major illnesses and injuries, operations, hospitalizations are very important, but just as important are any allergies. It doesn't matter whether it's to an animal or a food or grass or whatever it is, the doctor should know. So for instance, even though most of the time when I'm asked the question, do you have any allergies to medications? I say no, but I do have an allergy to most mammal fur. Just to let them know that, just in case it's important. Again, immunizations, are you up to date with them? If you have certain respiratory conditions, you may end up getting the pneumonia shot much earlier than most people do. Most people start getting it in their 50s and 60s, but there's certain asthma conditions, chronic obstructive conditions where you will get it sooner. And dietary status, do you have a varied diet? Do you eat well? And how much are you lying about that to your doctor? Because most people like to lie about that one. Now, the social history, and again, this is on the top of page 7, will also go into things like marital status and living arrangements. So again, including, are you happily married? Are you happy in your living arrangement? We've all had bad relationships, and sometimes we've had to continue to live with that person after we have wanted the relationship to stop just because maybe we had to get enough money to move out, or there could have been another situation. So what's been going on with that? Your current employment. Are you employed? Okay. What's your occupational history? Have you worked with harsh chemicals before? Did you work with asbestos? The doctor needs to know, about some of these. Military history is important too. Military history is not only good for the doctor to know in general, but also, again, was that person in war operations? A lot of the military, once they come home and start civilian life again, they don't always get the emotional care that they need. And so if the doctor's aware that, again, they've been in the military, they can, maybe guide them to areas if the person feels the need to talk to somebody. Other things that we look into, again, use of drugs, alcohol, and tobacco. And this includes what we call our social tobacco and alcohol use. One of the interesting things that I have learned is that there are a lot of women, specifically women in the 18 to 29 range, who are what we call social smokers. Now, I've always seen this, but I guess it's becoming much more prevalent now. They consider these women light smokers. And these are women who, and we see men who do this, it's not just women, but there's a higher prevalence in women who will smoke when they're drinking. They're not usually a smoker, but again, this has happened to me in the past. You're hanging out with a friend, again, it's been a long time since anyone could smoke indoors. So, you and your friend, you go outside, they have a cigarette, maybe you have one, maybe you have a puff of one. They want to know, even if it's just happening on occasion. It's good for doctors to know this, to be on the lookout. Again, past and present medications. So if a medication has not worked for a patient in the past, that's just as important. Other things that, actually it's not listed here, but it is listed on page 7, is level of education. Level of education is important because, like for instance, my mom's mom, she went to the 2nd grade up in Canada. When she was 7 years old, her dad died. She had 4 younger siblings, and her mom was a one-room school teacher. So my grandmother, basically at the end of 2nd grade, stopped going to school and took care of her 4 younger siblings while her mom went to work so that the family could survive. Now, years later, after she has her 8th kid, which is my mom, they moved to the United States. And it took my grandmother a couple of years to learn English. But about 4 or 5 years after they moved here, my grandmother had a total hysterectomy done. And we don't really know much about it because she didn't speak English very well. But one of the things that we need to think about is, how did the doctor describe why she needed to have this done? Again, her level of education was so low, using simple words. I have met more illiterate people who were born in Connecticut than I could have ever imagined working in Connecticut. I mean, I also met someone, I was working on the South Shore in Massachusetts, but keep in mind, there are born and bred people, born and bred Americans, who have always lived in New England of some sort, who cannot read or write. So again, that will require the doctor to describe their medication differently. Instead of using the name, they may have to say, it's going to be an orange pill with a diamond on it, so the patient knows. So again, catering to the patient themselves. Again, the family history. Very important. We want to know specifically about the health status of the patient's parents, their siblings, and their children. There are other family members that can be important as well, especially when it comes to certain genetic conditions such as colon cancer. Colon cancer and breast cancer, it's also important to know, are there any aunts and uncles? Are there any grandparents or any great aunts and uncles? Because again, those are other people that are also directly connected to your parents and their siblings. Um, but again, the family history is items that are only related to the chief complaint. So again, that if someone's having a cough, you might just simply ask, so how's your spouse and children? Are they sick right now? And then that could give them an indication, okay, this is something that's been spreading around, things like that. So again, what's related to the visit? Everyone's going to be, slightly different. So if you flip to page 11 in your book, you're going to see that underneath the code descriptor itself, we have 3 bullet points, 2 paragraphs, and then a whole bunch of notations. If you look at the first bullet point of each code, it's going to be the type of history. Our histories start at problem focused, then expanded problem focused, detailed, and comprehensive. And so as we go from problem focused to comprehensive, we get more complex. Okay, so a problem focused history, again, could just be a simple sick visit. Okay, so the cough, the doctor checks the patient out, says, I'm pretty sure you have bronchitis. I'd like to give you the Z-Pak for it. Problem focused, okay? We have one problem, we're able to figure out that problem, treat that problem. Expanded problem focus is getting a little more complex. Maybe this is someone that has, again, a cough, but maybe they also have asthma. Now we have some complications going on here. So there's a couple more things a doctor might need to take into account. Again, detailed history. So a detailed history, again, we're getting even more information about what's been going on. As we go up in complexity, we tend to also go up in the types of diagnoses that the patient has. So something problem-focused and expanded problem-focused is still something that's relatively common, easy to deal with. By the time we're getting to detailed and comprehensive, we're talking about, maybe the patient is having multiple problems that involve multiple systems. And so we're grabbing all sorts of history to try to understand this, especially if it's pointing to, a disease that they could have a family history in, like a diabetes or a hypertension. By the time we get to comprehensive, we are asking as many questions as humanly possible to best understand the history of the present illness. So again, a problem-focused history is a brief history focused on the chief complaint, okay? There's no review of systems, no past family and social history, and when you look at the audit form, it only includes 1 to 3 of the 8 elements of the history of the present illness. So again, this is something that's very straightforward, okay, where the doctor can go in, ask a couple questions, and figure out what's going on with the patient. Expanded problem focused. Again, we're doing a brief history of the present illness, 3 to 8 elements, or 1 to 2 chronic problems. Again, a review of system that pertains to the presenting problem, no past family or social history. Because for problem focused and expanded problem focused, again, they're usually things that are very simple to deal with. We don't need to know about the PFSH information. By the time we get to detailed, though, okay, we are looking at 4 or more of the 8 elements of the history of the present illness. And then we are looking at 3 or more chronic conditions. We're looking at an extended review of systems and a pertinent past family and social history. So again, now we're looking at a lot more information because we have a lot more going on in the patient. By the time we get to comprehensive, we're basically doing an extended history of the present illness, complete review of systems head to toe, and a complete past family and social history to really understand everything that's been going on. All right, so this is in your textbook, and if you like this, I would highly suggest you draw this in to your actual CPT book. I usually put it like at the bottom of page 3 or page 4 in your green guidelines for evaluation and management in your code book, because there's some nice spots. And again, all I do is I just take this information exactly as is, and I copy it in using just a simple ruler and a pen. And this helps me because here's the thing, you can't bring an E&M audit form to a coding credential unless you're going for a specialty. So if you're planning on seeing for your CPC exam or the CCA or some of the other kind of general coding certifications, you can't bring anything but your code books with you, but you can write this information in to help you out. And so as we go into the next breakdown of E&M, we're going to talk a lot more about how do we pick out this information. Okay, so let's talk a little bit about examination and medical decision making. So just like our history, our examination uses the same language. So what you'll notice is as you go through these codes, the type of history and the type of exam are almost always the same. So again, when we're thinking about if it's a problem-focused history, it's most likely going to be a problem-focused exam. But again, documentation is important. So when it comes to the examination, again, this is the physical examination that we're doing, okay? So we have 10 body areas, 12 organ systems. So on the bottom of page 9, going up to the top of page 10, in your guidelines, we have our body areas and we have our organ systems. And so again, first of all, we need to know whether we're using the 95 or 97 guidelines. And then again, we're only looking at the affected body systems. Problem focus, what is affected? So the lungs and the heart and maybe the upper respiratory, the ear, nose, and throat for a cough. Expanded problem focused is limited only to the affected body areas or organ systems, and anything else that's related to the poking and prodding of the patient. A detailed examination is an extended examination of all affected body areas and or related organ systems. So again, this is when we're looking at multiple parts of the body. Again, maybe it's nervous, it could be musculoskeletal, it could be integumentary. So when we have multiple things that it possibly could be, we're going to examine multiple body areas and organ systems. A comprehensive exam. So we have 2 different types of comprehensive exams. So we could do a complete single specialty, which means we check out every single portion of one organ system, or we can do a complete multi-system examination, which is what like our primary cares are more likely to do versus a specialist might do a complete single specialty examination. And again, this is another table you may want to draw into your guidelines. The medical decision-making table that we're going to look at is already on page 10, but the history and the exam tables are in your textbook, but they are not in your code book. So again, simple ruler and a pen. And as I will show you guys in our next video, I just draw them right in to my book. Now again, biggest thing, the extent of the examination is based off of the needs of the patient from gathering the history and the judgment of the physician. So again, if the physician judges that they want to look at this part of the body, even though you as the coder and biller go, why? It doesn't matter. It's their expert judgment. Again, if it's not documented, it didn't happen. Now, Again, the other thing to keep in mind is it may have happened, but you still can't bill for it unless it is documented, which is, again, what we want to remember if our physicians forget to document. So again, all of this must be documented in the medical record. We should be able to pull out all of these components from the medical record, or if the doctor does their own evaluation and management coding and we're checking it, we should be able to look at the code and go into the patient's medical record and pull out the documentation to make sure that the doctor assigned the correct code. Okay, so let's talk a little bit about medical decision making. So again, the level of medical decision making is going to be very different depending on the complexity of the patient's condition. So again, a chest cold is going to be treated differently than a severe chest pain. Both the chest, however, slightly different concerns. So there are three elements that we go into of medical decision making. The first part are the number of diagnoses or management options. And these are considered minimal, limited, moderate, or extensive. So again, in this case, minimal could be 1 or none. Limited could be 1 to 2. Moderate could be 3 to 5, and extensive could be more than 5. So you could think of it like that. As we're going up, we are kind of adding more diagnoses and more complications. The second part is the amount and the complexity of data to be reviewed. So for instance, if this is an urgent care, you have minimal or limited information that you have if you've never been there before. Versus if this is a primary care office that you've been seeing for 10 years, they're going to have more information on you, but also, what have you had done lately? Have you had lab tests? Have you had radiology? Did you see a specialist? So how much information does a physician have to go through to make sure that they know what's going on with your body? And the last part is the risk of complication or death. We call this morbidity and mortality. So morbidity is the risk of complication, mortality is the risk of death. So again, is it minimal? Is it low? Is it moderate? Or is it high? And this is, again, without treatment. So if the patient decides they don't want to abide by the treatment the doctor has given them, then that's a little different than the doctor treating them and the patient not getting any better. So again, we have to keep in mind what else is going on with the patient. We have a lot of non-compliant patients. So again, while history and exam use the terms problem-focused, expanded problem-focused, detailed, and comprehensive, medical decision-making uses 4 other different terms. They use the terms straightforward, low, moderate, and high. And again, if you look on page 10 in your code book, you will see the table of medical decision-making that labels this out for you. And again, a straightforward medical decision-making is minimal diagnosis or management options, minimal or no complexity of data, and minimal risk of complication or death. So these are going to be the simplest of cases. Low complexity is our limited number of diagnoses or management options. So again, for that person that has the really bad cough, it could be a cold, it could be the flu, it could be bronchitis. But if a patient has a history of bronchitis, it's probably going to be a low complexity. We have limited options. We're going to try antibiotics and see what happens next. Again, there's going to be a limited data that we have to pick up for that, and a low risk of complication, because the doctor is going to tell the patient, if you don't feel better in 5 days, give us a call back, or if you feel severely worse in the next day or 2. Again, moderate complexity. This is when we're getting to multiple diagnoses or management options. So again, when we're talking about management options, think about, again, things like diet, exercise. Also, think about whether someone needs to have a treatment versus a surgery. Those are all part of management options. So it's a combination of diagnoses and or management options. Again, we have a moderate amount or complexity of data. So again, this is going to be for maybe people who are going to see a specialist and they're bringing over a lot of records with them. Or this could be someone who just spent 2 weeks in the hospital and the doctor has all the hospital records to look through. The most important part of this is the risk of complication or death is moderate. So again, we have to figure out what can we do with the patient to keep them at their healthiest point. High complexity medical decision making, we have an extensive number of diagnosis or management options. So we have different choices, or we might have to do a whole series of different studies, labs and radiology and things like that to find out exactly what's going on. We're going to have a lot of data coming back because of that. And the risk of complication or death is very high. And so again, we need to utilize the provider's skills and the provider's knowledge to make sure that they are treating the patient the way they need to be treated based on the reason, that chief complaint, but also that they're documenting so that we can make sure the provider gets paid, especially for these cases that are very complex. Again, so management options, again, are the amount of diagnoses or the various treatments that a patient can have. Data to be reviewed, again, laboratory results, radiology results, and other tests and procedures, and medical records from other sources, other providers. Again, if the provider reviews the results, it should be documented in the medical record, especially if they review it with the patient. Again, something like the hemoglobin within normal limits, so that's coming from a blood test. Or again, a chest x-ray negative. Old records can also be requested and reviewed. Again, what if someone just moved to your area from Texas? They might be bringing 50 pages of their old medical record, and that is something their physician is going to have to read through. They don't necessarily have to do it right before the patient comes into the visit, but they will have to review it, and that can be grouped into the visit depending on the amount of data. Again, morbidity is a poor outcome. So continued sickness or complication. Mortality is the death. Again, so this is without treatment. Now again, obviously there are other diseases and factors that affect the risks of the patient, as well as possible medications. Diabetes is one of the big ones. Diabetes and hypertension tend to work negatively in the same patient. Again, age, whether they're very young or very old. We have all different types of risks. The urgency, so if someone just had a myocardial infarction, getting them treatment as soon as possible. Again, something like a ruptured appendix that needs to be done right now, bring them into surgery. So again, we have to keep in mind, we have 4 levels of risk. So again, the 4 levels of risk are going to be the minimal, the low, the moderate, and the high. So again, we want to keep in mind that all of these link back to this 3rd bullet point of medical decision making. So again, if the risk level is minimal, this is like a wasp bite or a bee sting for someone who is not allergic. Okay, something that is low would be, again, multiple bites, multiple stings. If something is moderate, again, now we're talking about some chronic illnesses. Again, they could be stable but chronic illnesses, or a chronic illness that is getting worse or complicated. So again, we can also deal with moderate risk for undiagnosed prognosis, like a breast lump. Again, what could it possibly be? Also certain acute illnesses and what is possibly going on with the patient. Pneumonia is considered moderate risk. Again, if the patient doesn't get better, they might need to be hospitalized. And then, of course, high is we have, again, one or more chronic illnesses, what we call a current severe exacerbation. So either an out of control condition, an uncontrolled condition, or a condition that continues to get complicated for a variety of reasons. So again, we also have to think about high risk are life-threatening injuries, again, myocardial infarctions, heart attacks, cardiac arrest, respiratory failure, hepatic failure. There are certain things that are always considered high risk because they are life-threatening. So again, this right here is on page 10 in your code book. So make sure to take a look at that. Okay. So we're going to do a little review to end this particular lecture. So there are 3 key components in evaluation and management coding. There is history, examination, and medical decision making. Okay, history includes the chief complaint, history of the present illness, review of systems, and past family and social history. Remember, our 4 levels, which is the first bullet point underneath our codes, are problem focused, expanded problem focused, detailed, and comprehensive. So that's key component 1. Key component 2, the examination. So again, this is the physical exam of the patient. Again, this is now the second bullet you will find underneath the evaluation management codes, and they use the same wordings as history. So we go problem focused, expanded problem focused, detailed, comprehensive. Key component 3, medical decision making. Again, terms change. So again, what we need to know is the number of diagnoses or management options, the data to be reviewed, and the risks that are involved. Again, in this case, the 4 levels are straightforward, low, moderate, and high. Remember, the other factors are the contributory factors, which we talked about at the beginning, the counseling, the coordination of care, and the nature of the presenting problem. So again, counseling, only if more than 50% of the face-to-face time spent with the provider will make the code itself. So if there's less than 50% counseling, we go by key components. If there's more than 50% counseling, we can use time as one of our factors. Coordination of care is, again, the work done on behalf of the patients. These are all the arrangements being made, talking to other specialists, setting up appointments, setting up testing, reviewing records from other facilities, making sure that we're coordinating all of our information. And then again, the nature of the presenting problem, again, which is the type of problem the patient presents with. And again, the nature of the presenting problem is basically what leads us to the chief complaint, which leads us back into the key components. And so again, when we look at our evaluation management code, so I'm looking on page 11 in your code book. We look at code 99201. Okay, we have the code descriptor, our 3 bullet points, a paragraph about counseling and coordination of care, and then a second paragraph about the presenting problems and the approximate time spent with the family. So again, keep in mind, this is what we need to know for E&M. Okay, so as we're going to look at our presenting problems, again, back in the reason for the visit. So this is all one big circle. Types of presenting problems, again, could be minimal, self-limiting, low, or moderate. We're also going to see high in some cases. Again, minimal may not require a physician. So this could be done by a nurse or a medical assistant. A blood pressure check would be minimal. Self-limiting are minor problems, something that we can easily take care of and has a great or good outcome in general. Low is there is a low risk without treatment. But again, we want to keep in mind that we want to keep our patients healthy. Again, moderate is without treatment. There's a moderate risk the person will continue to get worse or have a problem with death, depending on that morbidity of their condition. And high, without treatment, the risk is very high. So again, this is someone who needs treatment immediately and sometimes will require hospitalization because, again, their condition is putting them in such poor health. Again, time is direct face-to-face time based on the physician and the patient being together. This could be in the room at the office or at the bedside at the hospital. And again, we only use time as a basis for the majority of our evaluation and management codes when more than 50% of the time was spent counseling and doing coordination of care. If the patient is in the hospital, we also call it unit floor time. Unit floor time is when the physician is on the patient's floor or unit and is reviewing records, talking with the nurses, looking at their lab reports, but they must be on that floor or unit. The second they move away from that floor or unit, they go to get a cup of coffee, that's no longer considered time. So, this is where we're going to leave it for now, and we're going to pick up with going through our guidelines in the next lecture. So again, let's start with what are we going to find. So first we have a category at the top. Okay, so you can see this on page 11 in your code book. So the category of the patient status is new. The code is 99201. The place of service is the office or other outpatient visit. Okay, that's also the type of service, right? Because they're at the office and they're having an office or other outpatient visit. And again, for the evaluation and management of a new patient, which requires these three key components. And we're going to get a little bit more into how many key components we need to match up in the next lecture. We then have our 3 bullet points. It always goes history, exam, medical decision making. Our paragraph about counseling and coordination of care, and our paragraph about the nature of the presenting problem and time. So what I'd like you guys to do is I would like you to flip through your evaluation and management section. I would also like you to look at pages 1 to page 3 in your code book to see about all the different areas where a patient might have services and the types of services they will have. I will see you in the next lecture where we will break down our guidelines and start some coding. Have a great day.